We know that endodontics is one of the most likely disciplines in dentistry to attract litigation. Now, I don't know about you, but I'm pretty keen to keep up with current techniques that help me deliver the best and safest care to my patients. I'm Peter Norton, and in this episode of Henry Schein TV, we'll be taking a look at some exciting advancements in endodontic technology that help to minimise complications and maximise success. We're joined by endodontist Dr. James Whelans. James, thanks for being here.
Thanks, Peter.
Now, James, what are the main techniques or technologies you're going to be talking us through over the next hour or so?
Yeah, so today I want to highlight the new advances in the heat treatment of rotary files. I'll be demonstrating some very flexible files, the EdgeEndo X7, which is a beautiful file I've been using personally for 8 years. And then we'll be instrumenting a case, and I'll be using some bioceramic sealer just to give some examples of what materials are out there and stuff that us endodontists are now using. So EdgeEndo, I understand that has a slightly unusual but significant backstory. Yeah, so EdgeEndo, it's, you know what it is, it's up. Let me just jump to this slide right here. The founder of EdgeEndo is an endodontist, so he's part of the people, part of us, you know, part of the guys, the girls out there slugging it every day doing endodontics. So yes, he's an endodontist. He's not some person in a room locked up, making some crazy advances for science. He's out there doing treatments, but his backstory is he has a mechanical engineering degree in addition to endodontics. So he could see the issues that endodontists, clinicians face every day. And he brought what his advances, his knowledge in the mechanical engineering side over and produced some beautiful files. And I'll go over one particular sequence today, but there's a number of file brands within that Edge system.
Well, on that front, I mean, you mentioned the X7 system that I think you're going to be talking us through this evening. What other EdgeEndo systems might we see around the place? Yeah,
let's just jump to this slide here. So today, well, in Australia, there's some, in different areas of the world, there's some other additional sequences, but the main go-to file system of the Edge brand is the Edge File X7. It's a proprietary file system. It's only found in the Edge brand. It's a constant taper system. So what does that mean? It means it's all one taper, the 04 and 06, and then overwards the next system, going back to that slide, is the Edge Taper Platinum, which is a variable taper. It has changing tapers through the system. There's plenty of competitive file systems out there that have this variable taper. And what does that mean? It means you're kind of limited to the gutta percha you use. You have to, if you're using brand X, you've got to use brand X's gutta percha. Then Edge, going back to the slide, has the Edge Sequel Sapphire, which is a constant taper system, like the Edge X7. The nice thing with the Edge Sequel Sapphire is it goes all the way up to a size 90, which is quite rare in rotary file systems. So when you're instrumenting large palatal canals, or anterior teeth, particularly on younger individuals where the pops are very large, you can go ahead and use that all the way up to size 90. The Edge One Fire is a reciprocating file system. There's a lot of different brands out there that are doing the same thing, but if you're a reciprocator user, the Edge has that system. And then if you're a minimally invasive file user, the Edge V-File, there's only that and another brand that do that. So, you know, keeping shape skinnier. We've seen a lot of talk in recent years in endodontics about smaller prep sizes, keeping a lot of the original dentin or dentine available there in the pericervical region. You know, avoids potential cracks, failures from cracks in the future. So,
well, the slide mentions firewire. What does that mean?
Yeah, so let's just jump to that slide here. It's easier to talk through slides. Well, both of these here are files. The left file is the Edge file. The Edge itself is a heat-treated file, the firewire, I should say. Edge does also have traditional night-eye fire. just jumping back to me, it might be easier to discuss. So martensitic is meaning it's been heat treated to a certain degree. A lot of this is top secret. The file companies don't share this information. But just showing under the scope here, you can appreciate very flexible wire. Now, why does that matter? Well, the canals, we notice, are not straight, right? Unless you're doing very straightforward cases. Looking closer down at this molar here on this plastic tooth that's been 3D printed. So this is actually someone's real tooth that they've replicated. You can see there's many bends and turns. If we used a stiff file, which is in the ostensitic phase of metal, the old traditional files, many maybe 10 years ago, different generations, just like we see different generations in composites and bonding systems, we see that in the files as well. So in the old traditional ones, you'd be going down into these canals and you end up causing ledges in the canal system. Now with the more flexible wire, and there's a few companies that do this, Edge just does it really well, is that you can maintain the shape of the original canal system. Why does that matter? Well, obviously removing bacteria or vital tissue, depending if it's irreversible pulpitis or it's necrotic. Either way, if you're instrumenting vital tissue, you're leaving that substrate for potential reinfection in the future where bacteria could come in, live off and cause abscesses. If you're dealing with necrotic cases where there's bacteria throughout the whole canal system, you want to instrument as much of those walls as possible. Now, it's a three-dimensional instrumentation in addition to irrigation and activation and irrigation. But as long as you can remove a lot of that during the mechanical phase of instrumentation, which is why you want a very flexible wire to do that, you'll have better outcomes. And also, you know, obviously the most important part of endodontics is getting down into those last few millimeters down here. We can see that there's some ramifications and isthmuses down in these canal systems. Let me just go up a little higher in magnification. So if we don't instrument those areas, again, bacteria can live off that substrate, or bacteria will remain and cause infections to persist. So again, you want a wire that's flexible throughout the whole canal instrumentation process, staying centered on that canal as much as possible. There's no magical fire. Yes. Do
you mind just pulling the tooth down? Yeah,
sure.
There we go.
Yeah, there we go. All right. So there's not one magical file that will touch all the walls. I've done studies on this. There's not one file that does that, but there are files that do it better, and Edge-X7 is one of those files. So touching all the walls, removing that debris, and then following on with your irrigation, getting needle deep, getting your irrigation as close to the apex, not out the apex, obviously, and then activating it are all kind of the triad of having successful endodontics.
If you're watching us on 24, please feel free to send us your comments and questions, and we'll get to as many as we can. Depending on the device you're watching us on, though, you might need to exit full screen first. If you're watching us on social media, welcome. But if you'd like to submit comments or questions, you'll need to do that on the On24 site shown on your screen, because we won't see your comments or questions in real time if you submit them on social media. So maybe switch over to On24 now. James, going back to the slide, the high magnification slide of the files next to each other, obviously there was a bit of a difference in surface texture.
Yes.
Can you talk us through why that is and what the significance might be?
Yes, so let's jump back to that slide. So right here, the Edge file system has a smooth finish. It's electro-polished, and that's the file on the left. Competitors' files on the right. A lot of these, during the manufacturing process, these are grounded machines. They make these many files all at once. And in that grounding process, they have their striations, and you can see the striations on the competitor's file. And then that creates ledges, and ledges cause internal cracks to propagate during instrumentation, and that can also cause early file separation.
And that's cracks within the file
Yeah,
structure.
The files actually, during the bending instrumentation, there's stress on the metal. Just like, think of a coat hanger in the metal, we bend it and then it eventually breaks. This is going on while we're instrumenting. And so if you have a rough surface with a ledge, you've got to think there can be cracks that are going to propagate. The edge file is electropolished, a smooth surface, so it removes a lot of those, those imperfections during the grounding process. Another thing to note when we're going back to slides is the tip. A lot of the competitors, they hold the file tip in a vise when they're grinding these files, and you can see on the tip it's got quite a flat tip. That's kind of like the old locomotive, right? They're not very efficient. They get you where you need to go, but they're not going to get you there in a hurry. And in fact, in dentistry and root canals particularly, that pushes debris apically. It's called apical mud, and that's when we lose length. I'm sure we've all done cases and we're like, okay, I started at 18 millimeters, now why am I at 16 millimeters? Well, A, you've either pushed debris and you're blocking yourself out, or B, you've ledged, and that could be because the wire's so stiff, or you haven't done the right steps to get to where you need. Going back to the slides, the edge file, again, is smooth, and you can see the rounded tip. It's aerodynamic. Now, we're not driving Teslas on the street or sports cars, but in the tooth this does matter because we can, again, we can barrow through the debris. So we're cutting as we're instrumenting, right? And we want that debris to be pushed out. So when you get towards the tip, you want that debris at the tip brought up. If you have a flat tip, you're pushing it, and again, you're losing length. There are some ways to get around that, like recapitulation and active irrigation, but if you can just make the whole instrumentation process more seamless, it just, why not? Why not make instrumentation, easier in the chair? Let's be honest, dentistry is not easy, and and each tooth has its own story. I wouldn't be doing endodontics if I found it's boring. It's not boring, and every tooth is different. And with that, I want to be able to tell that story, get to where I need to, and have outstanding results.
Does the distance between the flutes of the file make a difference? Yeah,
so actually that's a really good question. Going back to that slide, you can see obviously there's distances in these flutes. This file is the Edge Sequel Sapphire on the bottom. The Edge Sequel Sapphire versus, I think we have this is the Edge X7. X7's more of a helical design. It's more tightly wound and it has a greater radius. So that's why I personally like the Edge X7. It's a very safe file because of that. When you have a greater radius, it means you've got more area of metal that's less likely to break. When you start changing to triangular shape or rectangular that's wound where the flutes are wider apart, yes, they're very efficient, but they've got less area to kind of support, and then they can fracture. Where the Edge X7, yes, the cutting flutes are a little bit more narrow. It's not as, let's say, fast at cutting, but it's safer. And to be honest, I don't really find a difference if they're wider apart or not. As long as they're done in the right sequence, I think you'll get to where you need to, probably about the same amount of time. I'd rather have safety as, in my hands, to be the utmost importance.
No, I certainly agree with that. Questions here wanting to ask if you have any comments about the likelihood of torsional fatigue with edge files, given their flexibility.
Yeah, sure. So all files, not just edge, are going to succumb to some type of torsion. Now, when we have torsion, obviously there's stress on the walls, and they're putting forces on those on the file itself. So cyclic is bending, and that's why we're moving the file back and forth. Torsionals, if you're pushing a file to where it can't go any further and it's really tight, and then yes, it can break. And that's actually the most common way for a file to break. Yes, so softer files, well, you'll see the torsional fatigue going on. And if you're working under high magnification or a microscope, and let me just jump over here and zoom in a little bit more. I think we can go here. So we can start to see the file unwind. Now, to me, that's a great asset of the file. I want the file to tell me, hey mate, there's too much stress going on down low, and it might be time that you switch me out. And that's why it's important you inspect your file every time you're coming and going into different canal systems, because it's just the high chance, let's say you didn't notice that and you went in and then it separated. I want a file that's going to tell me this is going to happen soon, rather than it just abruptly happening and now I've got to go digging it out. And if I'm a dentist, then now it's a difficult conversation. Have to refer on to a specialist to try and remove it. Not all can be removed, and then we have to maybe consider surgery. So obviously, yes, softer wire can cause more stress and unwinding, but they're also more resilient in the sense that they can instrument with that unwinding, but I wouldn't push it. It's telling me there is something going on in that canal system. Maybe I should do a little bit more hand instrumentation, or maybe I should drop back a file and make sure I have a better, smoother glide path before jumping up to those higher files.
I think you've just answered our next question actually in terms of the tendency to unwind. Can you suggest how to go about instrumenting narrow canals safely? Is there a particular sequence or technique you suggest? This person is talking particularly about mesial canals of molars, but it sounds like that's probably your suggestion on that front.
Yeah. So I particularly will go over later on with the technique that's recommended. That's the beauty with a constant taper system. You can read up on all different techniques. I like the crown down, to be honest. I find it a very safe technique, and that's where we're focusing on the coronal flaring initially, and then we focus more on the apical instrumentation further on. So I start with actually in a 2506. I'm not taking this to length, and that removes a lot of the stress on the file early on, and then I can get my smaller files further down and then less stress on that. Just think, on the higher up area, they're not touching those walls, they're only touching on that middle to apical third areas, so less stress on the file. And that's the technique I use, and we'll go through the glide path, hand instrumentation, all those areas.
You also mentioned earlier the concept of active irrigation. Can you talk us through what you mean by that? Yeah,
so obviously when we're irrigating, there's debris that we've pushed. Obviously there's isthmuses. Let's go back to this tooth here. These are areas that our files are just not going to reach. So the way we get this is obviously we let the constant moving of the needle and flushing of sodium hypochlorite, being the king of all irrigants. The stronger the better. We don't want to be diluting this to 0.5% because we're really not going to have enough action. But so we've got irrigant down below. Then there's many devices that you can activate. You can activate ultrasonic files. There's the Eddy, there's the Endo activator. There's some new ones in America, ScheinTV. They're very expensive systems. You really don't need the very expensive system, but you do need to activate that irrigant to get it into those isthmuses. Just remember, if you left that area underbrided, full of bacteria or full of tissue, there is obviously a substrate or bacteria that can remain and cause that case to fail, or potentially that's where you're getting that post-op sensitivity, or inter-appointment post sensitivity, where it's just not settling. So there's something going on apically, and that would be why activating the irrigants is very important.
We've had a question on just that, on the isthmus situation. How difficult and important would it be to instrument the lateral canals connecting the main canals? I guess a subset or a sub-question of that would be, is it actually possible to instrument?
Yeah.
Or do you have to rely on irrigation?
You oftentimes, listen, we're not seeing these. You've just got to assume that there. That's kind of where it goes to root hand surgery, right? We see failures on cases that look beautiful on the radiograph. Why is it failing? Well, these are isthmuses that we just can't get our instruments to. And these can be sometimes so thin that even the best of activating irrigants may not be enough. And that's why when we, as endodontists, are doing surgery, particularly on lower molars or upper molars, when you connect between the canals, you just assume that there's an isthmus running there and there's residual bacteria. And obviously the bacteria is so small we can't see. So then we have to go after our anatomical studies on how often are they there, and they're pretty much there all the time. So yes, you may be lucky to get into a lateral canal, and oftentimes with our irrigants, you may get some puffs out the side. They look really nice. They make you like, oh, I didn't expect that. What happened? All that surprised me. But like in this one here, even on a 3D X-ray, I mean, this is a young tooth. The pulp's quite large, but when we're working on very calcified cases, we wouldn't even know that's there. It'd be quite hard to even pick up on a cone beam CT. And why is that? Well, the slicing's just too wide, or the definition's just not enough to pick that up. So again, yeah, assume they're there, and that's why activating irrigants is very important.
Well, what is the actual sort of technique process of the X7 system?
Yeah, so I'll go through that whole system. I did want to highlight that Edge now does have these, well, they're coming out into Australia. I guess the plan is around Q4. But before we were at the main market they were coming in these packets, just like most files. But there was a need, I guess some practitioners in Australia were asking for them to be pre-sterilized. So this is the pre-sterilized pack here, and you obviously just peel them. I personally don't really find that, too handy. My assistants pre-sterilizing my sponges. I like my hand files, and I have my system. I have my approach, and so they're all put in and then already bagged, so that way I know they're pre-sterilized. These are, I guess, handy for people to keep them in the drawer, but oftentimes I find it's better they're already in a sponge ready to go. But yeah, let's jump to the technique slide, so we can have a look at that. Can we go? Yeah, all right. So here's the technique slide. This is just kind of a common way to use the X7. Obviously in endodontics, we're not jumping to files right off the bat. We've got the 10 and the 15. Now, obviously there's calcified canals where you may have to drop to a 6 or an 8. It depends on that canal, but routinely a 10, a 15. And then the Edge has a glide path file, which is the one in the picture. I actually use the X7 1704. I'll just show you that in the right here under the scope. I'll zoom in. So it's a very thin file. Again, throughout the X7 range, super flexible. Again, we're getting able to negotiate down these calcified canals. It's a 17 tip, so it is white, so you'd assume it's a 15, but it is a 17. It has got an 04 taper. So what does that mean? You need to get to a 15 hand file, which is an 02, making sure you are to where you need to go. And then once you've got that glide path initially, then you can go ahead and open up a little bit more with the 17. So they're just showing that here. And you can actually use rotary files by hand, particularly if you've got some really curvy roots. You can pre-bend. That's the beauty of these, and you can get in and you can feel around. You're highly less likely to separate doing it by hand, but obviously you're not going to get very far very quickly. That's why we use them in hand pieces. But again, that's a technique you can use. Then going back to the technique card, I discussed earlier my way of doing things, and that's with the crown down. And so that's where that 2506, let's just jump back to the scope, Brett. 2506, we can see quite a considerable difference between the 17 and the 25. Again, it's up in this coronal area where we're doing the shaping. Now, we're not taking it all the way to the end of the tooth. We're just flaring it in the pericervical area. In essence, this is like your old Gates Glidden technique. You're taking your Gates Gliddens down. The problem with Gates Gliddens are they're very stiff, and canals have dog bends and stuff like that. When you're taking very stiff files, you can actually cause ledges, and it can be very frustrating to get past once these ledges are created. That's why I prefer using a nickel titanium rotary file to do that initial open up flaring, and that's where the X7 2506 comes in really handy. Going back to the slides here, we've got for small canals, where obviously on the X-ray they're not too wide. I personally like to go to a 35 as my routine tip size, just because there's been studies actually by Sedgley, Australian endodontist that teaches in the United States, She looked at 3504 tip size being kind of your standard to be able to get an adequate amount of irrigant perfusion in the apical area. The greater quantity of irrigant you have in the apical area, the greater chance you have of annihilating, killing the majority of the bacteria and having successful cases. But so going back on these thinner ones, the smaller canals, the 2006 obviously can go further than the 2506. So we've taken the 25 down. Can we see that a little bit closer here? So right here, let's go back to the 25. You'll notice that we're probably about 1 millimeter shorter when we go to the 25. All right, so the 25 stopping right here. If we go to the 2006, obviously you can take the file further. So yeah, we're already about here. So what we can see is with the smaller canals, you can get that 2006 more or less to length. Now that's not a technique I use, again, because like I said, I like to go to the 3504. So jumping back to the slide, let's go back. I go always back to that bottom 30, 35, 40 at least. And then we have palatal canals, distal canals on lower molars that require larger files to be able to obviously instrument all the walls. And then we have anterior teeth that obviously can be up to a 90, like I said, up to 120, immature teeth, traumatized children's teeth. That's where, instrumentation is still important. There are some other areas in endodontics like revitalization, revascularization procedures where we don't instrument walls, but in necrotic cases, fully developed roots, that's why we need to go larger. We need to touch the walls.
Well, I understand you're going to actually sort of demonstrate the technique now, if
yes,
that works for you.
Absolutely.
So while you're getting set up, a few questions to ask you.
Sure.
How many uses of each file would you recommend?
Yeah, so I would recommend once. One, look where we are. We're in a pandemic. Things are transferring easily. There may be things in the future we may find out about that, sterilization may not kill. And there are obviously prions and stuff. Mad cow's disease was one of those. Would you ever consider having one set of files for the patient if they're coming back for a two-stage treatment? Yes. So I guess the ADA does have some guidelines on how to clean files. There is a lot of steps involved, and I think if you look at those steps and the amount of time you're having your assistants do that, and obviously we've had needle sticks and instrument sticks. There are, thick gloves, how well are they cleaning? Sure, but if you follow the ADA guidelines, there are those guidelines for those reasons. All manufacturers I'm aware of will state in their use, product use card, one-time, single use. The files are not as expensive as they were, and that's one of the the great things about Edge is it's not a high-price file. It's a great file, but it's not going to break the bank, and so that's the beauty. We can use a new file each time. We can break, knock on wood, no files. We all, are going to break files at some stage. Even endodontists break files. We're not magicians, but we know steps to avoid breaking those. And again, one-time use, you'd obviously avoid, less likely to do that. There are studies where they've looked at sterilizing, up to 5 times use and finding there's not a big, great loss in efficiency or breakage. Even in the heat treatment, they say that sterilizing actually kind of resets the heat flexibility. So there's not an issue. Some companies will say, oh, that may change things, but actually they've done studies on that, and that hasn't. Textbook 5 times, product manufacturer 1 time. What do I do 1 time?
Peace of mind, one time. Yes.
And when I'm doing a molar, think about it, I'm using it 4 times if it's got 4 canals, right? So it's under a lot of stress.
On that note, now that the Edge system is going to be pre-sterilized or come with a pre-sterilized option, would it matter if your dental assistant sterilized that as part of your established packet of different instruments? Yeah,
good question. So the way they do these pre-sterilizers is by radiation. So it's different to the heat sterilization that we use in our offices, right? No, So again, they've done studies on heat treated wire. Sterilizing doesn't change the file, doesn't change the flexibility. So no, that really, no.
Great.
Answer.
No, that's good to know.
Yep.
Well, let's go through the demo then.
Sure.
And see you in action.
Sure. All right. So here we've got a 3D printed tooth by B&L. It's actually quite a tricky tooth. It's not a very straightforward case. I'm just taking the 10 file. I already know that this length's 18 millimeters. And it's just good to show you. This is down MB2. Just using a watch winding motion. I'm not pushing a lot of apical pressure on the file. Again, taking it down the MB root, and the MB main canal. So now I've got a decent feel of the canal system with the 10. Gonna move on over to a 15. Just taking it down. Obviously, you know, we've got cone beam CT now, and this is something that I've started using a lot more, is you can get an idea of the length of the root. Not really an idea, actually a precise representation of the length of the root with the 3D imaging. So a lot of the software built in has length control, or length, and with the 3D tooth, you can look at the different angles and angulations of the roots. So you're now able to get a really good ballpark, unlike, you know, your periapical, where you can have elongation or foreshortening and really not be able to roughly gauge your length. So with that, I just wanted to highlight that that's a great thing with 3D X-rays, is you're able to get a really nice idea, a roadmap of the tooth, know what the tooth is like before even getting in. So now I have a mental picture of the tooth, the length of the root, how many nerves should there be there. Let's be honest, you know, most cases I get, MB2 is not seen on the 3D X-ray, but the root is broad enough that you know it's got to be there. And, you know, we'll attempt to, you know, remove dentin and look for that. And that's just the nice thing. Now we definitely get an idea. And sometimes there is no MB2, and we get the 3D X-ray and it's like the canal is centered, it's quite a narrow, not a very wide mesial buccal root. There's no reason to remove additional dentin searching for that MB2.
We've had a question about how you know in your hands where to bend the files, and is that sort of related to what you're talking about, the fact that you have a 3D representation of the tooth in your mind?
Yeah, so 3D, exactly. So the 3D's already told me, all right, this root's got this bend here. There's no unseen curve because now we can see everything. And I would say that not all cone beams are created equal. There are better ones, more pertinent to endodontics. You know, I personally use a Merida X800. It's, I think, very wonderful for what I do, but if you place an implants, maybe not so much. I can just speak on the endodontic side of things. So maybe your cone beam doesn't have that capability, or maybe you don't have all that software, but with the right software, yes, you get a good roadmap. I would say your hand files, the stainless steel files, are a better gauge of the curvature. You know, if you're pulling the file in and out and it's straight, you know, and there's no real binding, you got to know that, yeah, it's pretty straight canal. But if you're having a hard time getting down and just going back to this here, you can, like, if I just push, I can really just feel resistance. And I'm right now in that MB2 root. So I'm having to manipulate the file, moving it back and forth and getting it to right to that tip. And right now I'm at that MB2 tip, and now I'm moving that file back and forth and bringing it out. And like I said, you're going to notice this red dye, there's going to be no real file that's going to remove it all, but we're going to remove a majority of it. If we can remove 80 to 90% of it, hurrah, all right? So now we're going to go use this handpiece here, this cordless handpiece.
At which point do you use an apex locator?
Yes. So apex locator, once you've got you opened it up, you know, got a file to where, again, I've got the 3D X-ray, so I'm already know roundabout. But once I can feel patency, I can feel that file kind of pop through, and then I pull back, and now I'm back in the canal system. So early on, you don't want to be doing this later on. You don't want to be powering through that minor constriction of the apex, and now you've ruined your control of the gutta percha. Although in retreatments or long-standing infections, we'll have resorption down there, and that's what the 3D X-ray does. It shows us, oh, there's something going on with the apex. There's resorption. There's been an active infection, and then we'll know that maybe we'll have to make our own apical stop. Just showing you that not everything's as straightforward as it seems. But yeah, so smaller files, I wouldn't say nothing more than a 15. And then once we've got that length, then we can obviously stick with it. And then take a file shot, that helps. Some of these newer generation handpieces, like the Merida here, this has a built-in apex locator. So you got this on the patient, you can input the right data, it'll start to reverse once you get to the working length. So the technology is moving faster than we can keep up. And I think now is the most important time why dentists should be really keeping up with CPD. Just because, if you were living in a cave for the last 5 years, you'll come out of that cave and you'll be like, hold on, am I a dentist or do I need to be a tech wizard? Is this just software changes, scanners, 3D printing? If you're not with it, you're really falling behind. So yeah, and things like this make it easier, make treatments easier, and you don't want to be going bald by early days. We're all fighting that age.
No, if there's a way around it. No.
Yeah, I think so. But I mean, if we can de-stress as much as possible, hey, here we go. So let me go back with this. I'm putting on that 17.
Do you mind just holding the motor in front of the foam block for the camera?
Yeah, sure. Let me just make sure. I'm going to zoom out a bit.
Or just you.
Yeah, so this is the Merida.
So just in front of your foam block on your tray.
Yep. All right. Yep.
So in front of the block.
Oh, okay.
There we go.
Yeah, so this is the Merida Tri-Auto. And this has got their built-in apex locator. Right now, the settings, I've got this on at 500 rotations per minute, and it's got 4 newtons per centimeter torque control. Just a heads up, if you are breaking files or having a really hard time, set these parameters lower. Just because manufacturer says 500 at 4 doesn't mean you can go lower. I wouldn't go above it. But going above it means you're spinning faster. Putting additional torque, higher torque, means that it's going to likely break in the canal system. If you turn that down to 2 or 1, turn the rotations down to 250, 300. Yes, it'll take longer, but it's a lot safer process, and it kind of helps build up confidence again if you do break files or have a hard time getting down. Obviously, I'm at the manufacturer's settings on this one. Now with flexible files, again, if we've got these bent, we're going to have a really hard time getting into the canal. So when you come out of the canal, you want to straighten them up. You want to get into that canal before activating. And see how I'm moving. Plastic teeth can pull you, so it's not a real true representation of denting, but it's as close as we're going to get. We obviously want to, you see how I'm moving back and forth. We've got to remove the debris. Normally we'd be irrigating in between, but with this demonstration, it's actually quite hard to, again, do all those steps. So again, I'm in the canal system, and now I'm activating.
Just increase the magnification.
Sure, no worries. All right, I'm up to 16 times now. You guys have a good view on that?
That's good.
Okay, so back into the canal, and I'm back activating. I'm right at the tip already, removing that debris. I've got really good control on the handpiece. I don't want to be, and I've got good fulcruming. Okay, so there we go with that. Now I want to take the 15 just to make sure I've got enough debris out of there. I'm recapitulating. So we've got enough. Here we go.
And when would you be irrigating in this process?
So I'll be irrigating throughout this. Even early on, even with your small files, yes, you're not going to get the irrigation to length, but it provides a lubricant. Sodium hypochlorite is a lubricant. EDTA is a better lubricant. It's obviously softens dentin. So I prefer that on really calcified cases. But overall, if you ever put sodium hypochlorite on your gloves, it feels real soapy, right? So it's the same. It helps as a lubricant. And obviously it kind of starts, if you're having a hard time finding canals, you can fill the chamber and watch for, for bubbling. Obviously that shows you where, potentially necrotic material is. But yeah, throughout the instrumentation process, you would be irrigating. I'm not going to irrigate in this demonstration, but here's just showing you, we'd be irrigating throughout, getting enough fluid, obviously to help remove that debris that's being built up during the instrumentation. Now, if we follow that sequence card, we're going to go to the 2506. Now we're just doing this as the coronal flaring. We're not taking to length. I'm not pushing it until I've got apical pressure. Just 1 second, we've got to make sure we get in the canal. All right, great. Irrigating between. Now I'm going to drop to the 2006. We can take that about 1 millimeter longer, right? So I showed you on that before we instrumented that it will take you before instrumentation about that. See tremendous amounts of debris forming. All right, I'm still about a couple of millimeters shy of the apex. I'm going to get my 10 again, kind of recapitulate, remove some of that debris that I've built up during the instrumentation. And remember, during instrumentation, we're putting debris on all the walls. So after I do my sodium hypochlorite and activate, I actually do EDTA, I let that sit, and then I also activate that because that creates a smear layer during the instrumentation process. And so that smear layer is dentin mud pushed into the tubules. And if it's a necrotic case, you need to open up those tubules to flush out that bacteria or remnants of tissue. So I'm recapitulating here. And now going back to that technique card, we're going to do a 3004. Again, getting it into the canal before activating. And so right now, moving that file up and down. Right at the apex on that MB2. We just get a lot of that bit of that mud away from here.
Now, just to be clear, we're not really spraying triplex air into an actual tooth. You're just
right. I'm just doing this to obviously just remove the debris. So we're not using water here. Oh, I mean irrigant. Right here, you can see we're right now at the apex. And so it's very important to remove that mud. So there are studies that have shown this mud that gets caught in here during this file flexing, particularly on the non-heated treated files. It'll wedge in those cracks and cause early file separation. All right, now the 3504. We're not spending too much time down there. We're getting in and out. We're not lingering. All right, so we're at the 3504. I told you that's kind of where I'll stop, unless I feel that the instrument's not really touching the walls in the apical areas. So just recapitulating. Remember, we're building up mud even with those aerodynamic tips on the edge. Irrigating, activating the irrigant, going through the whole triad, like I said, and then it comes to the obturation point.
So what does the obturation process then look like for a tooth like this? I mean, for the purpose of the demonstration, we're not going to prepare the entire tooth and obturate the entire tooth. We'll just focus on those 2 canals. But what does the obturation look like?
Yeah, so after obviously we've done that whole irrigation triad of, you know, sodium hypochlorite, EDTA activating. Some people use chlorhexidine as well. But yeah, routinely, most cases, sodium hypochlorite, EDTA. And then we're drying the canal system, obviously paper points, remove out as much moisture as possible. What's one of the new innovations in endodontics is hydraulic condensation. It's a newer technique. Some may kind of find it similar to the old single cone technique, which, listen, it's kind of a quick way to get where you need to. There was a lot of problems with the single cone technique, particularly the sealer being used. The sealer has shrinkage. But the newer generation of sealers, let me just zoom in on this, is Endo Sequence. This is made by Busa. It's a BC sealer. This is their new high flow. It's a little bit more radiopaque than their traditional bioceramic sealer, but it's just a beautiful product. Bioceramic meaning it's biocompatible. Macrophages, you know, our little trash receptors cells that come in and clean up. This can be, if you extrude this, they'll come up and eat it up and make it go away. Where our old epoxy sealers like AH+, there are a number of epoxy sealers, that was one of the main ones. You'd extrude that, it doesn't go away. It goes like a rock. It's like epoxy, you know, and people use that in the building industry. This was used, you know, in osteopathic medicine for hips and knees. I use this as cement. So they decided to bring it over into dentistry. It's a really nice product. It's got a high pH of 12, the same as calcium hydroxide. So it's antibacterial. When you extrude, let me just extrude a little bit. These are actually the new minimal usage tips, which you can buy separately. They do come with these standard tips. I do, let's see if I have any standard tips. I don't, but the standard tips you actually find that you waste a little bit more. But you can just see that it flows really nicely. It's osteoconductive, so osteoblasts like it. They feed off of it. It sets in the presence of moisture. It's hydrophilic, so it's very dimensional stable, and there's almost no shrinkage. So very stable material to use. It's been out on the market for about 8 to 10 years. It's just more recent in Australia. So it's not like this new material, oh my God, we're going to see a ton of failures. No, it's been used in medicine for a long time. It's been used in dentistry in other parts of the world for a long time. When I was talking about hydraulic condensation, it's more about the actual sealer than the gutta percha. The gutta percha is used as a vehicle to get the sealer. Let me get here. Go into a 16 times. With these minimal wastage tips, you can actually see how flexible these tips are, and you can see already I'm flowing. And when I'm flowing here, I'm starting to pull back. Just like when you would do an impression. Starting to check. Now, the sealer itself is around all the walls. The gutta percha now is just used as a vehicle to push that sealer into the isthmus, into the lateral canals. So again, like I said, it's very dimensionally stable. They even have their own gutta percha, which has got bioceramic impregnated into the gutta percha itself. I'm using the EdgeEndo gutta percha here. Just using this right here. Getting that to length. Now, I'm using 30 04s. I do find on these tighter canals, sometimes you do have to drop a size. Now, the files themselves are machine made, right? They all match certain specifications. However, gutta percha, most of it's hand rolled. It doesn't meet precise specifications. So oftentimes you'll find yourself maybe having to drop one size. It's not the end of the world. But as long as it matches where your working length was, and you've got some tug back on that gutta percha. If you don't, then you know now that gutta percha is not fitting, and when you burn it off, it's potential to pull it back. And again, if you don't have an adequate apical fit, then you can have leakage and obviously bacterial problems later on. I am going to use a heated beta, excuse me, this is the B&L Alpha. It's a little heated device. Just kind of highlighting again advances. You know, back in the day people used Bunsen burner. Obviously you can't control the heat. It's very dangerous. Fall on the patient, fall on the, you know, start a fire type stuff.
Patients love hearing gas.
Yes,
gas burning behind them. Yeah.
Burning smoke. They might be running for the hills if you see that. The nice thing of these are they're very easy to use. I'm just going to drop again magnification. This is the unit here. You can actually control the heat by pushing that button. I like the 200, and then you just activate it by pushing these little buttons on the side. It starts making a beeping sound. I'm not sure if you can hear that, but again, with the hydraulic condensation, you know, in the original form of that, you would just burn off at the orifice. I don't advise that. I still do warm vertical condensation, so I'm still taking my plugger down as deep as I can here. Got my cones out. I'm just going to flip this tooth over so we can get a better idea what's going on.
So some questions about the actual canal cleaning process. Do you brush the sides or do you just place the instrument centrally?
I do brush the sides. So when you are instrumenting, you want to try and touch all the walls. Now remember, these files are flexible and they're constantly shape forming. And so they are inherently touching the walls as well. But if you're on a large oval canal like that palatal or the distal of a lower molar, you're going to have to move that file around to touch all the walls. Obviously, these two canals were very tight and narrow. There wasn't really a need for that. But inherently, the file's doing it as well. But on the ones that it's very large, you'll need to obviously touch those walls. I'm going to now use the B&L Beta unit. This is really handy as well. Just push the button. These are all cordless. I just like these for the convenience, really. You're not having to plug things in different rooms. They hold the charge for a number of days. So if you're doing endodontics in a large group practice, and many different dentists doing the root canals, you can have maybe in a couple of boxes and just grab the box. Boom, it's in, and then at night time have the assistants leave it on the charger. These will last at least a couple of days, but I would just say if you're doing this often, end of the night, just get in the habit of doing that. It flows really great. I'm just going to go back down here. We'll get into the high magnification. So you can just see the gutta perches coming out almost like liquid. So it heats up very quickly, and that's another thing I like about this product. It does that. Now I'm just putting it down into that canal. Can we see that here? Yep, it's good. I'm backfilling with the gutta percha, and then I'm going to come in back and with my plugger to condense. So here we go, condensed. You know, the one downside of the sealer is it can be really sticky on the walls. So you can obviously spray it. Once you've finished obturating, you can spray it. Actually, a little compound of alcohol removes the sealer quite nicely. You could even just get your hive speed, not touching the walls, but just kind of putting it in and spinning it, kind of spreads water everywhere to remove it. And then if you're placing immediate core, then you'll go ahead and do that.
Have you had any experience or any thoughts on MTA-based sealers?
Yeah, so listen, MTA is in essence a bioceramic sealer. There are a number of brands out there. The MTA, I think the original sealer they had, it was in a 2 syringe and different tips that you had to mix it and pre-mix it. I just like the convenience of the BC sealer personally because it's already pre-mixed, there's less wastage. But ultimately, yeah, MTA is fine. MTA is known to stain teeth. And that is actually an inherent problem with that material. And that's why, you know, we're seeing a lot of endodontists moving away from that material. Still a bioceramic in that sense, in that category, but one that doesn't discolor. And that's where actually Busa makes BC putty, and they have it in a fast set, which is in a little syringe or in a little putty in a dish. I've actually got a few cases we'll jump to just to show you kind of three-dimensionally using, you know, Ep17 with the sealer, and then using the BC bioceramic putty in routine surgery, and the success rate we're having. You know, it's a wonderful material. Again, a high pH, easy to place. We're not you know, the problem with MTA and like perforations or placement is it's very difficult to place. You've got to have that map system. You've got to have the system mixing it to the right specifications, and then it gets quite flaky. The Busa product's already pre-mixed. You're just scooping it up and placing it. Almost like Cabot, but it's not. It's a bioceramic.
Given it's pre-mixed, what is its setting reaction? Like what actually catalyzes the
moisture.
set?
So hydrophilic, so moisture will set it. There's no way we can get everything bone dry, so there's always going to be moisture in the tubules. We're doing surgery, then obviously there's blood that'll help set it. But yeah, just that's how it sets over time, and obviously oxygen as well. If you leave this out over time, it'll start to oxidize.
And once you've done the alcohol and before you're placing the core, do you use any restorative materials to seal the orifice of the canal?
Yeah, so there are some orifice barriers. There is a Permaflow purple one I think I like to use. It's here I am type thing, you know. Some people old school Cabot, people Fuji. If you place in core right off the bat, I mean, just think about it. If it's a dual cured core material, you could place that directly on it. You try and get as much bonding as possible, and that may be where some of the orifice barriers can interfere with bonding on the pulpal floor. So if you can get your bond on the floor and build up, why not? That's just my philosophy. Obviously, there's many different philosophies out there. But yeah.
We're here to hear from you this evening, James, so thank you for being so forthcoming. Now, if you're watching us on social media, remember, unfortunately, we won't see your questions or comments in real time if you post them on social media. So if you'd like to submit a comment or question, please switch to the website that's shown on your screen now, and that will allow you to send questions and comments that we'll be able to see and address given the time constraints. So you have some clinical cases. Can you sort of, I mean, we've seen it in action in person now. Can you sort of show us in a patient style environment?
Sure, I'd love to. And these are all done recently in the last couple of months. So just moving over to this slide here, there's obviously on a lower 4-6. You can notice it's very calcified on that mesial root, and it's got quite a significant curvature in the apical third. This case was previously initiated by a dentist, and obviously they probably had a hard time locating the canals, and hence for the referral. To the right, you can see cone placement. Obviously in this case, every canal had a different size. That's why it looks like a rainbow of colors in on that cone shot. And obviously this was doing a very similar sequence to what I just showed you earlier. And if you can look really carefully into that apical third on the mesial buccal root, you can really appreciate how that sealer flows through the lateral canals, maybe not where the instruments stayed center on the main canal, but into the little apical lateral canals. And it's very hard to do that. And if you're using a stiffer file, there's a chance you're going to transport that apex and straighten that canal up in that apical area and leave those 1 or 2 millimeters undebrided. And that's the problem with the stiffer files. That's why, honestly, flexible firewire or any heat-treated wire is very important. Obviously, the more flexible, the better, I find, because you want to stay, we're instrumenting anatomy. We're not instrumenting train tracks, you know. And so that's why it's important to have a file that stays centered throughout that clinical case.
You mentioned that each of those canals had a different size after preparation. We've had a question on that. Can you explain why you tend to use a larger taper in smaller canals? So a larger taper, so 06 taper in smaller canals and an 04 taper in medium to larger canals?
Yeah, so again, I mentioned that that's not my personal sequence. That's just one that's been recommended by Henry Schein. I again use the 06 taper just initially as an orifice opener. I'm not shaping the whole canal system. The majority of my walls are all done at an 04, which is a smaller taper than the 06. I just personally find 06 a little bit too large. It removes too much dentin overall. So 04, I'm doing 30, preferably 35 if I can. On that case there, with those bends, I'm now having to start to decide if I go larger, I may be having breakage. So that's where in that case there, that case dictated from what I was seeing during my hand instrumentation and what was observing on my files, that we need to go different shapes for different canals.
You mentioned orifice openers, question on that as well. Would you ever use an orifice opener?
No, not me personally. Again, I like the flexibility of something staying centered, not causing ledges. So that's why I don't use, like a Gates Glidden or a Mueller or something like that. So a month or, yeah, so.
Well, going back to the bioceramic sealer, do you find that retreating a case that has been obturated with a BC sealer is any more difficult than other retreatments?
Yeah, so a good question. That was kind of an original concern a few years ago, is the stuff kind of setting like concrete, like the MTA, which can be quite hard to remove. Now remember, there's a gutta percha through the middle. So when we're retreating, we're removing the gutta percha. Removing the gutta percha now allows us to remove from the walls. And when we do retreatments, we go larger, we go a couple sizes larger than the original, because there's obviously potential for infected dentin circumferentially down that canal system. So by that larger file, we're removing that infected dentin. So no, I don't have a problem doing the retreats with the using that bioceramic sealer, again, because it's the gutta percha in the middle that allows us. If it was a three-dimensional seal with a bioceramic, yes, I definitely anticipate some problems and it would be a very challenging case, but that's not the case in this technique.
So what's the next case to discuss?
Yeah, great, thanks. Do we go? All right, yes, we finished that case. So this is just another case, a necrotic case, 3-6. Symptomatic. I just wanted to highlight, that oftentimes distal canals have, on lower molars, have two canals. And here you on the microscope image on the top right, there is two canals. Now those two canals connect, so almost like a figure eight in essence. And then on the right, on bottom right, we've got our cone fit, just showing the sealer flowing nicely throughout that system. Oh, wrong way, sorry. So we're looking here before both of these roots had lesions, and then at the end on the right, we got nice centering of the canals. You can see that we haven't transported the canals, and that's the beauty of the X7. You notice that your canals always feel centered. You take your x-rays, you're like, it's not off to the side, it's not off here, and it's because this metal's so flexible, it's appreciating the original anatomy. And then the nice thing about the sealer, yeah, I've got a couple of little puffs there. I'm not concerned. Again, it stimulates bone healing. It's osteoconductive. The osteoblasts are going to come in and feed off of that hydroxyapatite, which is part of the sealer. It feeds off of it, and the high pH is also going to help remove any residual bacteria that may be there.
So if you were to take a review film of that tooth,
yes,
in a few months' time, would you expect to see those puffs gone?
Yes, we'd expect to see those puffs gone, absolutely, and that's what we find.
So do these technologies have any place in things like sort of root repairs, for example?
Yeah, absolutely. So let's say, someone has an iatrogenic, perforation, or we're doing root surgery. That's where the Busa BC putty comes in really handy. It's like I said, it's already mixed. We're just scooping it out and placing it. Well, I'll just jump to a case actually where I used the putty on a repair. This is just to highlight the main points that I mentioned earlier about the high pH, resistant to washout, no shrinkage, very biocompatible, very radiopaque, no mixing required. It's antibacterial. So this is a case that was referred to me with a persistent, radiolucency. Patient was having symptoms on an upper 2-2. Diagnosis was previously treated with chronic apical abscess. So there was a sinus tract involved. And you can see on the bottom right on the cone beam on that coronal shot, you can see a break in the buccal plate where that sinus tract would have formed. Of note, when you get these cone beams, you can really get to appreciate what's going on. You can notice that lesion's not really centered over the root canal. So it appears like maybe the root canal worked, but there's something else going on. Is there a lateral canal? Is there something that's harboring bacteria and causing the patient to continue to have symptoms and not have resolution of the infection? So in this case, there was a lateral canal. I went in with the microscope, resected, obviously, still resected the apex, just because studies show there can be a high potential bacteria on the outside of the root, particularly in that last few millimeters. So that's why we resect a few millimeters. And then I'd stain the root end with some methylene blue dye, and under the microscope could actually see a lateral canal. You can see in the middle that I use my ultrasonics to prep into that, just like my retrofill, which we use the special endodontic surgical tips, and then I'm placing the putty, and then you can see the follow-up in 6 months later, complete resolution. So you see tremendous healing. Patient was asymptomatic, sinus tract was gone, the radiolucency is obviously now gone as well. So really nice healing. You can also use the material, like I mentioned, in vital root therapy, which MTA would have been used in the past, like in regeneration or on vital pulps. This is a case, the issue again is the staining. You don't want to, stain a young kid's premolar off the bat. It was a very unusual case. This was actually, I was, originally thinking it was a dens invaginatus, but it was actually just a malformation. There wasn't really an invagination, just a lack of the enamel coming together on the top, which you would think, okay, was there this enamel sac? No, there wasn't. It was just caused bacteria to get in, and there was early caries in that tooth. So let's just go back here. So I decided, the tooth actually wasn't responding, but when we went in, we counted vital tissue. So we decided at that time to do vital pulp therapy. And so here are the steps right here. The one on the left is where I'm seeing this caries, like orange mush, removing that, and counted the pulp tissue. And now I switched after we broke about right before we broke through, but we're still on clear, dentin. Then I used a clean burr, removed a couple of millimeters, so doing in essence a spec pulpotomy, which is a partial pulpotomy, and then irrigating with sodium hypochlorite just on the surface of the pulp. You can use it as a surfactant. It's not going to cause devitalization, but it's going to sterilize, in essence, disinfect the walls, any potential residual bacteria you've introduced in there, and then you're placing the BC putty directly on top, and then I placed an immediate core over that, and so provided a outstanding result, and obviously we'll monitor that for continued root development, and if we don't, then we can consider going to a regeneration procedure.
We've been asked for you to repeat the name of the material that you place after your obturation. Can you tell us what that was?
Material,
you mentioned it was here. It was easy to see.
A dual cured core material. So the Permaflow Purple. I think it's an ultra dent product. It's purple. It's an orifice barrier. It's in flowable form. So you lacquer, you etch. I believe it has a self-bonding property. You'll have just obviously verify that. And then you place it, and then you just light cure it, and then you can place whatever over top, your next core material or whatnot.
Okay. And what are your thoughts on thermoplastic obturators with plastic carriers?
Yeah, good question. I'm personally not a fan of those. I've had to retreat a ton of those because they actually do work in a lot of cases if they're done right. But what can happen is the gutta percha can come off of the slip off the plastic device. And so normally what we'll see is, remember I was telling you about the apex being the most critical, the last couple of millimeters area where we're going to have the best result if we have three-dimensional seal, three-dimensional irrigation. Those plastic devices, the gutta percha is going to pull off and you'll just have this kind of plastic tip in the area and there's nothing around it. So it provides a breeding ground for bacteria. Now they have the gutta core products that obviously get around that, but we do see that they often are just not placed properly. I may be biased just because I've had to retreat a lot in America when I practice there, because obviously it's quite popular in certain dental schools. They'll teach that system just because it's easier to obturate with. Now with the hydraulic condensation, in essence the gutta percha is like a heated device, except it's cold, it's pushing the sealer on the walls. So I find that system's actually a lot easier, and we're finding a movement all over, in the endodontic realm of that, going from the old traditional ways to the more bioceramic methods of obturation.
You've actually segued immediately into the next question, which is about carrier-based thermofill GP and whether that could be used with a BC sealer to get a good result. Yeah,
Sure, it could still be used. If you're a fan of that, then absolutely, you can use it, because again, it's pushing the sealer into the walls. I would say anything new, obviously play around with some plastic teeth or extracted teeth. Plastic teeth, the nice thing is, or plastic blocks is, you can actually observe what's going on, not so much in extracted teeth.
And have you had an experience with the EdgeEndo files as an activator or cleaner at the end prior to sealing a tooth?
Yeah, so I've actually played around with those. It's a Busa Brasser file. It activates in essence by moving it, whipping the irrigant around. Again, I personally actually use the Eddy. It uses an ear sonic handpiece and the plastic tips. I find that just really gives me a lot of nice results internally. I see a lot of effervescence, a lot of exchange. There are some activators out there that just put it on your finger and vibrate it. You'll notice if it doesn't vibrate very well, it's probably not vibrating very well inside the tooth and activating. Maybe it's doing it well up top, but where it matters is down in the apical area. So just that would be a good way. But yeah, the XP is well known for that. Sure.
And which cases would you choose to use NiTi versus X7?
NiTi? Well, X7 is a NiTi. Yep, so
that
it's a heat-treated
well.
NiTi. You may be traditional. Listen, when we retreat cases, I use stiffer files to remove. You need something a little bit more stiffer, so that's where I'm using traditional. But yeah, no, other than that, no, I'd find that heat treatment's the way to go. It's just a newer generation. Again, it stays centered on the anatomy where the traditional stiffer NiTi wouldn't. But again, yeah, if I didn't clarify that, yeah, the X7 is a NiTi. It's a different phase of NiTi over traditional.
All right, now we're not expecting to be a lawyer here, but we do have a slightly curly question.
Yeah.
Is it a medico-legal requirement for a general dentist doing molar endo to have a microscope?
I would say as much vision as you can. There's so many things I see every day that I'm like, wow, if I didn't have a microscope, I wouldn't know how I would have accomplished this case. Listen, it's not, yes, we can say in the perfect world, yes, in the practical world, as high as possible. I'd say at least probably 4.5 loops. And these are on pretty straightforward cases. Calcified cases, if you don't have adequate light and magnification, which is what all endodontists have, then you're going to end up breaking things. And then it's going to be frustrating for you. And then you're also passing on a problem that it's not the easiest to recover from. So yes, if you can, great. If not, have at least a 4.5 loops with like a dual halogen light that provides tremendous amount of light. Look at the lumens. Look online for good reports, not the cheap $100 lights. We're talking a couple of $1,000 lights. But you'll notice overall in your general dentistry practice, you'll be doing better crown preps, better restorations, better veneers if you have that better light and magnification.
And have you had any experience with perm evolution sealer as it compares in your hands to something like BC?
Yeah, no, I haven't. So.
Okay.
But there are, what I am seeing is there is kind of an explosion of bioceramic materials coming to market. Just make sure, you do your research. I'm not sure on the quality controls and that coming from those companies. But yeah, that's all I could say is just do your research. Like I say, a product's been around for a couple of years is probably a good one to go with, just because we know that we'd be seeing failures coming out, and we did see that back in endodontics with Resolon. I think that kind of put shivers down a lot of endodontist spines. It was a material that they thought was going to replace gutta percha, and then after a few years, we saw tremendous failures. It was just breaking down the material. So again, stand the test of time.
And what is the name of the smaller size BC sealer tips you're using, and where can you get them?
Yeah, so these are the minimal wastage tips. I'll just jump back to the scope. Let me zoom out on that. Yeah, so Henry Schein sells them. You can see they look in essence like an acid etch tip to this point, but then they have this flexible tip that you can allow you to get further down, and then when you're obviously injecting, coming back, they come in, I think, in maybe 20 in a little dish. But yeah, it's a new product, allows for better placement of the material. I think the ones that came in the box, one, they wasted a ton of material, so you'd only get a few cases out of it. But these ones just allow you to have better placement overall. You could also place it on a pad and then place it on your gutta percha tip and place down. I just personally feel that probably wouldn't get enough the sealer down on the walls. I use actually Linentulo a lot, the little spiral thing, to place a lot of sealers, particularly on those cases with isthmuses, where I know that there's going to be a larger canal system. I find that it gets the sealer on the walls and gets it into those lateral canals much easier.
I think you touched on this before, but with BC and GP, so BC sealers and GP, is tug back still important?
Yes, it is.
And why is that?
Yeah, so you need obviously a good seal in the apical area. Otherwise, if you're not getting tug back, then potentially the cone's loose and you're not getting the sealer everywhere you need it to. With tug back, now you know that tip of that gutta percha is fitting in that last millimeter, half a millimeter from that radiographic apex or on that minor constriction, and having a proper seal. You don't want to tip. Again, that's kind of like that thermofill scenario where the plastic tips out and there's no gutta percha around it to provide a proper seal.
And after doing most of your canal preparation, would you ever use EDTA as your final irrigant? And if so, how long would you leave it in the canals for?
Yeah, so I don't use it as a final. I use it as a middle irrigant. So sodium hypochlorite throughout, instrumentation. Again, it's a lubricant. If it's very calcified, I may go earlier on to EDTA. Then I'm activating my sodium hypochlorite, and then I'll place the EDTA. I use 3 to 5 mils of that irrigant, letting it sit for a few minutes, activating it, getting it into those isthmuses, removing that smear layer, and that's what EDTA is. It's not an antibacterial. There may be some limited antibacterial properties, but overall it's not well known for that. And then, so now you've removed that smear layer where potentially the bacteria is still harbored. Then I go ahead again with the sodium hypochlorite to disinfect as the final. And I sometimes follow up with isopropyl alcohol. That's just something I do just to kind of dry out the canal system as well.
All right. How do you know that the tug back is happening at the apical third of the GP point and not in another part of the canal?
Yeah, so you can, when you pull the cone out, you can actually get an idea where it's fitting. Obviously you can see little marks. normally if it's up higher, it just wouldn't fit well. And obviously you've got to do a cone shot as well. So when you do your cone fit X-ray, you may see that it's not down properly.
Okay, and can you give us a quick comparison of the X7 and Edge Platinum systems, please?
Yeah, sure. So Edge Platinum is a variable taper. It has its own system, I think it's SX through F2, F3. So you follow that kind of that cookbook approach. And variable taper meaning the file itself has different tapers throughout the system. Where the X7 is a constant taper. So constant taper meaning it has the same taper from the tip to the end of the file, to the cutting surface. With constant taper, it's a little bit more of a universal system globally. So then you can now look at, there's many options for gutta percha. Now, obviously I liked using the Edge gutta percha, but now you can have X brand X's gutta percha as long as it's constant taper. You can also have brand X's paper points, because it's constant taper. So that's just particularly in this like limited supply chain issue we're having. When you can have issues, maybe there's not gutta percha available for that. Well, now you have many options. It's like the medium gloves. I can go to any company that has medium gloves. So that's preferably what I use, because I have many options. If I'm out of paper points of gutta percha, I can go to other sources. But with the Pro Tape, the Edge Taper Platinum, you're limited to that. Now, that's not wrong. If that's something and it does well or works well in your hands, please, by all means, don't start looking to change if you're getting the results. Just kind of limitates you on that system.
Okay, there have been some recommendations to sanitize or decontaminate GP points prior to using them. Does that interfere with the bioceramic impregnation you mentioned before? And I think the suggestion is to sanitize them in sodium hypochlorite and then dry them. How do you go about drying them without distorting them?
Yeah, it's a really good question, Peter. Listen, like I said earlier, the controls on the gutta percha is a little bit different to the manufacturing of files, right? Files are all done by machine. Gutta perchas, oftentimes hand rolled. Sometimes they're injected in these little forms, but potentially they come unsterilized. So we need to disinfect them, and that's where there's classic studies. I think Gomez is one that comes to mind, where you disinfect it for a minute. I think they've even had studies for a few seconds, but according to the ADA, I believe in their guidelines, it is a minute. They found, some people have looked at 10 minutes. They found that 1 minute's sufficient. And to answer the other part of that question, does it interfere? Not to my knowledge. So obviously, I'm not touching the gutta percha ever with my hands. I'm grabbing the gutta percha. It's been placed in a little dish, or you can have on gauze. You can have it closed over. You can have already selected your size. Then as you grab it, you can pull the cone out. Sorry, I've already grabbed it. Let me grab. Yeah. So, and then you're just wiping as you pull out. And
no interference with the VC component?
Not that I'm aware of, no.
Okay. What are your thoughts on one-file endo systems?
Yeah, listen, there's been a movement in dentistry overall to try and speed everything up, right? How do we get to this amazing result as quick a time as possible? But just from what I've seen, these one files, they can work in some cases. They just don't work in all cases. Majority of cases, I would say, they don't work in. And they actually can sometimes take longer. What we can find, particularly the one file, is a reciprocating system. They'll fill it with dent and mud. It's a safe technique. So it's good for the novice. There's the one learning rotary, reciprocating. But it's not good if you want to kind of minimize your preps, kind of constrict. You've got different sizes, like that one case I showed with 4 different gutta perchas. You're not going to get that with that one file system. So it'll get you where you need, but is where you need right? In my opinion, it's not.
We're running close to time, so possibly a bit of a curly one. If the BC sealer itself is so able to be cleared away by macrophages, why is it the BC putty is then resistant to washout?
Yeah, so it's a different formulation. It's similar chemically, but it's a lot thicker. So as you saw on that slide, I put that it had a high high tensile strength. It's the facet sets in about 12 minutes. So it goes rock hard. It just has like a property that speeds up the setting time. So yeah, sealer takes maybe about 24 hours to set. The putty and particularly the facet, 12 minutes. So yep, sets very quickly. There's a sandwich technique which all endodontists will know about, where you can actually inject a little bit of sealer into the retro prep and then follow through with the putty, and that helps provide a better fit internally. And then we can use little micro pluggers to place it. We have all these cool little toys in endodontics, but the facet would be the way to go if you're concerned about washout. But I mean, MTA, that was a massive problem. It just washes out and you almost feel like you place it and then it just dissolves. And that's what you don't see with this, which has kind of revolutionized, doing surgery.
Excellent. When would you do single-step endo? The suggestion is that given your US experience, that perhaps there's a bit that goes on in the US. Yeah. So listen, that is a US philosophy. I think it's now Europe as well. I do find the culture here is quite conservative. Dressing multiple times until it's symptom-free. In theory, they've done studies and they've found no differences in success rates. They've actually, in some studies, depends. And obviously, we can pick and choose, cherry pick what studies we're going to say. There'll be the other guys or other girls on the other side of the fence saying, oh, this study, that study. But there are studies, and they've had Cochrane analysis studies, highest level of evidence showing that there is no difference in success rates of single versus multi-visit. But when do I do purulence? I can't get it under control. Maybe there's too much fluid in the canal system. So then I am concerned about my cases not setting. So that's just my philosophy. But yeah, we'll see where you'll have the traditionalists that'll keep dressing, and and there's also a different approach. It depends how well you can get to where you go. If I don't get to where I need, I'm not doing it in one, and that's the whole thing. And that's what's the concern about pushing single step, is what shortcuts you're making, and that's where I was kind of not a big fan of the one file system, because you take shortcuts, we're going to see poor outcomes later on. But if it's done right, if I get to the right size, I'm irrigating properly, I'm activating my irrigants, yeah, sure, that's when I would consider doing it in the single step, as long as there's not an active infection, swelling. These are kind of contraindications in my opinion. Sounds like very sound advice. Well, unfortunately, we're out of time. So James, thanks again for being with us on Henry Schein TV and giving us an update on some pretty exciting developments in endo technology. Yeah,
thanks Peter. Thanks Henry Schein for having me tonight. It's a great opportunity to chat about this stuff, and I'm glad, I hope you all learned something. That's the main thing about this.
We certainly did, so thanks for your efforts.
Thank you.
And thank you for being with us. If you're on the On24 platform, you'll be able to download your CPD certificate directly from the platform. And if you have any questions about what we've discussed in this episode, check in with your Henry Schein rep. Thanks again, and see you soon on Henry Schein TV.